Myself, Dr. Chetan. I am going to present the long case number 5. A 28-year-old female, native of Huzurabad, informant self and husband, educated till masters and working as a IT employee, brought to the hospital with complaints of nil urine output for 12 hours post delivery. History of presenting illness. I would date back my history to May 2022. She got married in April 2022, and in May she had a missed period. She confirmed pregnancy. She screened pregnancy with urine UPT, and after 2 days she went to the hospital, and there she was evaluated with complete blood picture, urine routine, and blood pressure and sugars were checked, which were informed to be normal. In return, while traveling in bus, she suddenly had a spontaneous abortion in May 2022. Then again she had a missed period in October 2022, which she confirmed pregnancy with UPT, and then she consulted in a local nursing home. There she was booked for antenatal care, and she was evaluated with complete blood picture, blood pressure, and sugars, which were informed to be normal. And during antenatal care, she had total 4 antenatal visits. In all antenatal visits, she was informed to have normal blood pressure and normal sugars. In early second trimester, around 18 weeks, she underwent a routine ultrasound and fetal scan, which were informed to be normal, except for 6 mm calculus in the right kidney. She was prescribed iron and folic acid tablets, and antenatal period went uneventful. At 36 weeks of gestational age, patient was admitted in view of fluctuating fetal heart rate and planned for elective LSCS on the next day. During antenatal period, she doesn't have any history of significant pedal edema, headache, blurring of vision, altered mental status, rash, photosensitivity, arthralgia, or any history of muscle weakness, abdominal discomfort, any history of febrile illnesses, or hematuria. And she was never informed to have any history of oligo or polyhydramnios. And there was no history of any Ayurvedic or herbal medicine intake during antenatal care. And emergency LSAS was done on 23rd of May this year, after which patient urine output suddenly dropped to less than 30 ml over 6 hours. Then she was referred to a...
Is it immediately after cesarean?
Yes, ma'am. She underwent cesarean around 4:30 or 5 a.m. in the morning, and after that urine output was dropped. There was no urine output. It was around 6 hours. It was only around 30 ml. Then she was referred to a multi-specialty hospital in Karimnagar in view of reduced urine output. There she was evaluated with complete blood picture and routines, and she was informed to have, her husband was informed to have severe blood loss, low platelet count, and raised liver parameters, and referred to NIMS for further evaluation. And the course in NIMS in local hospital, she was informed to have creatinine of 2.6, and NIMS her creatinine was around 5 at the time of admission. And she underwent 1 session of CRRT on day 1 with left femoral non-tunnel catheter, and after, with one unit of packed RBC transfusion. And after that 1 session of CRRT, she underwent daily hemodialysis sessions for 8 days, and during the 8 days she doesn't have any significant urine output, and both husband and patient doesn't know the amount of urine output they have. They were saying there is no output during that 8 days.
Even now?
No, ma'am. During that 8 days, first 8 days. Patient was admitted on 23rd of May in NIMS, ma'am. I examined 17th of August. Okay. So 53 days after the admission. So then after that daily hemodialysis sessions for 8 days, then she was shifted to alternate day hemodialysis sessions, and meanwhile after 1 week of femoral non-tunnel catheter, it was changed to right IJV non-tunnel catheter. And after on day POD 13, she was shifted to general ward, and on POD 14 she noticed output of around 400 ml over 24 hours. During this course of 14 days, she received another 3 packed RBC transfusion. So total, she received 4 units of packed RBC transfusion. One in local hospital where she was referred after a cesarean, she was informed to have fever, ma'am, 1 episode of fever spike. Patient general status improved and she underwent biopsy, renal biopsy on 7th of July. And she was discharged after 3 days of biopsy. She was in biopsy reports. Attendants were informed that her kidneys were not working properly, and she may require long-term dialysis, and she may require renal transplant also in the future. After 1 month of right IJV non-tunnel catheter, she was shifted to left IJV non-tunnel catheter, and she underwent fistula left RCF creation on 4th of August. Meanwhile, on 5th of August, she had a right loin pain for which she was evaluated locally, and she was informed to have swelling of the right kidney. She was referred to NIMS again, and NIMS she was evaluated with CT abdomen, and she was informed to have obstructing calculi of 8 mm, for which she underwent right DG stenting. And she was also informed to have there was a decrease in kidney size when compared to maternal ultrasound, which both kidneys were around more than 8.5 centimeters in the maternal ultrasound, and now the kidney size were around 7 and 7.5 centimeters. Currently, the patient is on. Currently, patient is having more than 1 liter of urine output per day, and she is on weekly twice hemodialysis session, alternating with the second week of only once hemodialysis session, and with left IJV non-tunnel catheter, with intradialytic weight gain around 400 grams. And the first obstetric history G1, she had a spontaneous abortion less than 10 weeks.
The baby is alive now?
Yes, ma'am. Baby is alive. The baby weight was around 3 kgs, active, and no post-op problems. Past history, there is no history of bronchial asthma or tuberculosis or coronary vascular disease or CVA in the past, and no significant renal history in the past. Personal history, she takes mixed diet, non-smoker and non-alcoholic, bowel habits regular, and now she is having around 1 liter of urine output per day. Marital history, she is married, non-consanguineous in April 2022. Husband age is 32 years. And the family history, she was born out of a non-consanguineous marriage, 3rd in order. All three were girls, and the first 2 siblings had 2 children each, and all 4 were normal vaginal deliveries and no complications during the pregnancies. Medication history, currently she is on iron folic acid supplementation and calcium tablet.
Any history to suggest alternative form of dialysis was done? Any other special form of dialysis in terms of plasma exchange done during the dialysis sessions?
No, ma'am.
Is it important?
Yes, ma'am. If you suspect of plasma pheresis can be done.
That history also should be included.
Summarizing the history, 28-year-old female, G2P1L1A1 with history of first trimester abortion in first gravida, now presented with immediate nil urine output post LSCS.
Totally asymptomatic antenatal period.
Yes, ma'am.
Without any hypertension.
Without any hypertension and no end organ like blurring of vision, no headache, no hyperemesis. Now presented with pregnancy-related AKI, now in acute kidney disease, and now on maintenance hemodialysis. My syndromic diagnosis, pregnancy-related AKI, KDIGO stage 3, with now in acute kidney disease, probably progressing to chronic kidney disease, dialysis dependence. Etiological diagnosis, my first differentials could be septic AKI with DAC, disseminated intravascular coagulation, and second would be thrombotic microangiopathy, and the third one with significant intra blood loss leading to vascular volume depletion state, and
There was no overt postpartum hemorrhage. So
no
what,
no
what
overt
the reason
postpartum.
can be.
No overt postpartum.
She had sudden abdominal pain and immediate LSCS was done, isn't it?
Yes, ma'am.
So, if you are suspecting a blood loss,
It was not an emergency LSS, it was elective LSS. She doesn't
some
have.
fetal.
Yes, ma'am. Fluctuating fetal heart rate, and for that she was planned for elective LSS, ma'am.
What was the blood pressure at that time?
Blood pressure, they were informing it was around 110, sir.
So they were she had a high blood pressure.
No, sir, no. Even when in local hospital and coming to NIMS also, blood pressures are normal, and she was taken for CRRT on day 1, sir. And the fourth differential could be acute fatty liver of pregnancy, considering all elevated liver enzymes, and the fifth with considering one abortion, spontaneous
You
abortion.
can't say all diagnosis causes of Saki.
APLA might be lower in the order because
Unlikely.
Successful. AFLPX, agree.
So tell me one after other. Sepsis, DIC was the first differential
What are
diagnosis.
the points in favor of sepsis?
points in favor of sepsis. She had a acute febrile illness post-op, and she was informed to have.
She had a surgery,
Yes,
isn't it?
yes, ma'am.
From LSCS.
And she was informed. Attenders were
And had
informed-
fever post-operative.
Yes, sir. Yes, ma'am. And she was informed to have, attenders are informed to have elevated counts and low platelets, which could be reason.
In favor of
this could-
DIC.
Yes, yes. And second possibility.
TMA, what are the points against TMA?
Against TMA, no hypertension, even in post-op period, sir, and
Other points
And
in
coagulopathy,
favor, requirement of repeated transfusion and low platelet count, all those things are in favor. But absence of hypertension is kind of a glaring. There are instances where there are some explanations for that as well. We can't straight away rule out.
Can this be still HELP syndrome? Low platelet, elevated liver enzyme.
to classify as a HELP syndrome, blood pressure should be at least in one sense after 20.
Usually associated with preeclampsia, but it can happen without preeclampsia.
Yes, ma'am.
Rarely it can happen. But what is the point against? Strong point
No
against.
recovery.
Deteriorated even after delivery, isn't it? That is a strong point against a HELP syndrome.
And even AFLP down the order because elevated liver enzymes are there initially, but there is no recovery post-op.
What is the sort of renal injury in AFLP usually? No, severity of renal injury.
AKI incidence is less compared to TMA.
DVD of
Much more severe liver injury and
Coagulopathy.
coagulopathy, hypoglycemia.
Yes.
All these are in favor of, and usually happens in the third trimester
Yes.
before.
And APLA just considering one spontaneous abortion.
This is complete anuria immediately after surgery. Anything
Yes.
else is coming to you? You want to re-explorate her abdomen?
ureteral.
She may have a solitary functioning kidney. Somebody might have ligated the ureter also. That also should come into your mind.
Change in deficiency of the fetus can lead to mother this kind of a situation.
If
Which enzyme deficiency in the child fetus can lead to AFP of
long chain hydroxycyl CoA
Pachydermatous.
D.
What happens to the child fetus after the birth?
Fetus.
Maybe SLE, flare. Can that explain postpartum occurrence of acute kidney injury?
Yes, sir. SLE flare can happen immediate postpartum also. But no, this active urine
I
sediment.
can explain hemolysis, I can explain thrombocytopenia, uterine activity. But the incidence is very rare. You have to remember that also. We have come across that. Absolutely no clue whatsoever. Anti-Marcham and all that. First time, SLE making its appearance in a very florid way post-partum. And in our, actually, I came across one patient with done test postpartum cardiomyopathy. Patient was in cardiology ward. So it occurred for some good Samaritan to look into the urine, which showed proteinuria. And creatinine 1.2, that also was considered as normal. And luckily we were brought into the picture, and then it turned out to be SLE, and she made a very smooth recovery after steroids. But it is rare, very rare. But any acute kidney injury happening after delivery, the possibilities are very few. One is a postpartum eclampsia, TMA, and SLE flare.
Will you differentiate an SLE flare from a preeclampsia and third trimester pregnancy?
One is the active sediment, ma'am, and then pregnancy generally C3 levels will be on the higher side, and if it is a low normal C3 levels or low C3, we should think of a lupus flare in the pregnancy.
It is not usually useful. Usually it will be normal only, from high value to come to normal and not be low. Active sediments and high titer of your antibodies will tell you that this is SLE flare.
So very unfortunately, this lady also suffered with nephrolithiasis.
Yes.
No? But normally, what is the relationship between pregnancy and urolithiasis?
So, in pregnancy, generally there will be ureteral dilatation because of as a smooth muscle relaxation, and there will be urinary stasis. And second is gravid uterus compresses is extroverted and can compress the right ureter, and the right ureter enters the pelvic brim at an acute angle at the pelvic brim, sir. So chance of compression is less. Chance of compression is more with urinary stasis, and there will be increased calcium excretion in the pregnancy with urinary stasis leading to stone formation.
But at the same time, no, the dilatation of the system facilitates passage of the stone as well. Some people, right? So the same kind of scenario like sepsis in a non-gravid state that somebody has experienced, the other patient would also have gone in for such a serious AKI.
Sir,
In what way pregnancy has made a difference?
sir, pregnancy is a procoagulant state with increased production of procoagulants and decreased fibrinolysis and decreased thrombomodulin effect on endothelium, and increased platelet aggregation is there. So chance of thrombosis and DIC is more in pregnancy. So pregnancy AKI, septic AKI especially, has severe outcomes than the non-gravid.
So she was told that the kidney pathology has reached a point of no return.
Yes, sir.
So what could be the pathology there?
Sir, my pathological diagnosis first will be acute cortical necrosis, sir, considering nil recovery and no recovery and progressing to ESRD, and the second could be severe acute tubular necrosis, but generally we'll expect.
No, but severe acute tubular necrosis, nobody will paint such a bad image, you know. There are chances that it, if not complete recovery, at least partial recovery can happen. So your first diagnosis is right, acute cortical necrosis. Why acute cortical necrosis more common in the obstetric setup?
There will be increase in the kidney.
You have also told us about the blood loss.
Yes, sir.
So when
What causes cortical necrosis?
so blood
Some
loss
less
happens in
supply.
the road traffic accidents which do not develop cortical necrosis. Liters of the blood go on. You give say patient recovers, but in obstetric conditions, even little
Many people
more of
develop
the
sepsis,
PPS
many
can
people go in
patient
for
develops
hemorrhage,
cortical necrosis.
but not all of them develop cortical necrosis. Cortical necrosis happens in two important clinical settings in India. One is obstetrics, the
Second
other
is
one?
snake bites.
Yeah. What is the commonality between the two?
Both are
Procoagulant state. So The thrombosis has to happen at what level to cause cortical necrosis? For instance,
medullary
artery-
junction.
arteries. Why it happens? Procoagulation.
Relative
What is the classical animal model that taught us this?
it's a Schwarzman mouse model, sir, where
Schwarzman's Horner-Early phenomenon. Can you explain what it is?
yes, sir, where they have given IV endotoxin, lipopolysaccharides. One dose resulted in cortical necrosis in pregnant mouse and gravid mouse, and two doses required to cause cortical necrosis in non-gravid mouse, sir, which suggests there should be a first hit phenomenon to cause a cortical necrosis in non-gravid mouse, and which is not required in the gravid mouse.
So what does this finding suggest? But it is found that lipopolysaccharide has been given and one group developed cortical necrosis, other no. Right? So what does this finding suggest?
You already told, no? Procoagulation.
Chance of microvascular thrombosis is more due to procoagulant state of the pregnancy.
Anything associated with the endothelial function?
Decreased in pregnancy, there will be decreased VEGF.
So this is all procoagulant. Any procoagulant state is provoked by endothelial functions.
Diffuse endothelial dysfunction and procoagulation. So without biopsy, can you find out cortical necrosis of the kidneys? How do you
Yes,
diagnose?
sir. Investigation of choice, please see contraction at CT abdomen, sir, where we can see a reverse rim or peripheral rim sign. And in X-ray, generally after 3 to 4 weeks of cortical necrosis, there can be dystrophic calcification seen.
Tramline calcification. Why it happens? The two lines, what do they represent?
Sir, two lines represent the peripheral line of active circulation receiving from the collateral, sir, and the dead tissue.
In the medulla, no, the corticomedullary junction. So where there is access for calcium to reach over there.
She required almost 4 blood transfusions.
Yes.
What happened actually? Where was the blood loss? She's underwent the routine electric cigarette sections. She had 4 antenatal checkups.
Sir, it could be a conjunctive coagulopathy.
She had such a bad figure. But what are other features of that?
Sir, she was informed to have elevated altered liver parameters, probably elevated bilirubin. They didn't say that it's elevated bilirubin. It's my suspicion. And second thing is platelets are also low.
So what happens in pregnancy, when the smaller amount of the blood loss, we dispose them for the severe ATN or cortical necrosis. Is there any correlations with this hemodynamic phenomenon happening during these periods? वो अगले पीरियड में ब्लड लॉस होते हैं पेशेंट को cortical necrosis नहीं होता, does not happen in the first trimester. But during the peripartum period, if there is severe loss, the patient develops severe ATM or cortical necrosis. So what is this? Can you correlate with this hormonal changes happening during this period, and then the compensatory mechanism?
So during pregnancy, the cardiac output increases first by 40 to 50%.
So that is
But
good for
yes, sir. But there will be decrease in peripheral vascular resistance due to nitric oxide, relaxin, and progesterone itself acts as a
So during the
vasodilator.
peripartum period, when delivery is going on, your hormone level of relaxin and progesterone is very high. So what is the impact of this relaxin and progesterone on vessels?
Vasodilation.
We call vasodilatations. So because of that effect, whenever you have blood loss in road traffic accidents, there is compensatory mechanism of the vasoconstrictions to provide blood supply to the important organ. There, under the effect of these hormones, it is lost. So this is the reason, and already kidneys functioning at the maximum, and already hypertrophied kidney. There is kidneys, GFR, everything is high during the pregnancy. So compensatory mechanism, but this is one contributory factor. It is not the sole factor. One contributory factor that predispose them for higher degree of early cortical necrosis. That does not come considered. So either there will be ATM or there will be acute blood loss in comparison to other. So that is the one, and definitely more importantly the endothelial dysfunctions, hypercoagulability state of the pregnancy. These are all predisposed altogether. Mechanisms why these patients are predisposed for higher degree of cortical necrosis. So you would like to do biopsy in this patient?
Yes, sir. Biopsy done, sir.
Biopsy was done.
Yes, sir.
What was the finding?
She has to go for transplant.
Okay. Findings they are not aware. Suppose you have done the biopsy, what you will ask? Still there is some diagnostic dilemma is there that fine histologically patient is having pachycortical necrosis. Why this happens? Now the patient is for renal transplantation. So anything comes in your mind how to go about proceed for the renal transplantation?
We had to rule out TMA by sending genetic analysis, sir. Complement analysis.
It is fine. So before this patient has very well, any histopathologist has done this histological examination. So you will try to find out something which will suggest no, probably there was some evidences of thrombotic macroangiopathy in the biopsy histology.
Light microscopy suggesting of a ghost glomeruli suggests acute cortical necrosis, sir. In that situation, thrombotic microangiopathy can be missed.
So do you think this is the pachycortical necrosis or this is the diffuse acute cortical necrosis?
Sir, diffuse cortical necrosis only, sir.
Why?
Since he is dialysis dependent,
But from where urine is coming?
some part of
1 liter of the urine is coming from.
Such a situation.
So they can see the pathological hallmarks of thrombotic macroangiopathy. They can say, oh, probably there are some thrombotic macroangiopathy, fibrin thrombi are seen. And so probably that might be the one contributory factor, you can proceed for that. So that might be histologically, but definitely that does not rule out, as might be the from area where you have done the biopsy, might be ghost glomeruli, you might not be seeing any findings. So definitely you have to go for the evaluation of the complementary regulations. So why this patient did not have anything throughout the life if there was any complement dysregulatory pathway abnormality, and this happened
So
during
it
this.
is precipitated by pregnancy.
Still, I have a feeling that there was concealed antepartum hemorrhage.
Yeah.
Probably because that explains everything. Now, abruption may not always have overt bleed.
Yeah.
She has history of blood transfusion received also.
That could have caused, because the so-called sepsis, fever, and all that, it is fine. Sometimes a severe gram-negative blood can cause havoc even without fever. I agree, but I strongly believe there is a requirement for huge amount of transfusion, and without hypertension, probably there is a concealed bleed, and that was not revealed to the patient or husband, or they might not have understood even if it was told to them.
Concealed hemorrhage are not uncommon to have done. It happens. Where it happens and how it predisposes the patients for this kind of condition. Where this concealed hemorrhage can happen. Abruptio placenta. This condition.
What are the two important causes for antepartum hemorrhage?
one is placenta previa and second is abruption, sir.
In which is associated with AKI?
So abruption is more associated with AKI, sir.
Why not placenta previa? What is the difference between the two?
There is a release of there will be increased microvascular thrombosis in
Why?
increased thromboblast in
Release of tissue thromboblast. Okay. Placenta previa to cause AKI, the bleeding should be massive and unattended, appropriately not managed then only going for AKI, placenta previa. Whereas abruptio placenta, there is a release of the tissue thromboplastin. So that initiates the thrombotic process. That's why we are doing it. What are other causes, obstetric causes of AKI?
Sir, trimester first trimester hyperemesis gravidarum and septic abortions and even urinary tract infections with pyelonephritis. And after first part, first trimester, it could be preeclampsia disorders, and even urosepsis is there, and antepartum hemorrhage, sir, and intrapartum excessive blood loss, and postpartum hemorrhage, and acute fatty liver of pregnancy. Lupus flare can happen at any time, and TMA.
So suppose a previous pregnancy, atypical HUS happens during end of second trimester or early third trimester. How do you manage? Very precious pregnancy, patient family insisting to continue pregnancy. Is it possible?
So we should look for end organ damage, and if there is no end organ damage, and plasmapheresis can be done, sir, during pregnancy.
Atypical HUS, can you continue pregnancy? Whereas AFLP and all, we say immediately you have to go for the delivery, induction of labor. Huh?
Pregnancy can be continued.
So you can go ahead with plasma.
Delivery will not alter the course of the disease.
That will not alter the course of the disease. If feasible, the situation is okay, you can go ahead with plasma.
You said her kidney size was 8 centimeters initially and then something like that. So explain that.
Initially, it was around, they attended, it was more than 8.5 centimeters during pregnancy, ma'am. And
Is that her original kidneys, prepartum
we
kidneys?
can't say, ma'am, because there will be increase in kidney size by 1 to 1.2 centimeters in the pregnancy.
Okay. Then after delivery coming to 7 centimeter, will you consider it as contracted kidney? That is her original kidney size, isn't it? It has increased to 1 to 1.5 centimeter during her pregnancy. By what time after delivery it comes back to her original state?
12 weeks.
Actually by 3 months it comes back to original state. You should not say that kidney has been contracted on repeat ultrasound, isn't it?
Yeah, but this suggests that maybe there was some chronicity.
Yeah. 7
Why is
centimeters.
it down to this size postpartum?
They've done biopsy, but
Yes.
probably numbers are maybe.
Yeah, or maybe that report
So
is not ready.
rapid contraction happens when there is diffuse cortical necrosis. Can happen and can have this fibrosis, you can contract within 2 months. So that is not so, but when you approach this patient now, you have to come because the patient is for transplantation. What will be your first test, second test, third test? Complement dysregulation with pregnancy. What first test you will do? Because you have to there. The Brown test is there. Lot of tests.
First is complete blood picture, sir.
No. Tell me, blood picture, leave it because you don't have it, it's just filling the blood. So tell me, for the complement dysregulations, you have to go for transplantation.
Sir, antifactories antibodies,
So first test, tell me,
C3.
have you heard the name of ADMTS therapy?
Yes, sir.
Is it important in
Yes, sir.
pregnancy?
Yes, sir.
How it is important in
Sir,
pregnancy?
in pregnancy during late second and third trimester, there will be decreased ADM ATS activity and increased 1
What
million.
happens to Adam TS13 activity in normal pregnancy? Increase normal, decrease
Decreases at the
MCQ.
decreases in third trimester.
Increases even in normal pregnancy, isn't it?
So those who have the partial deficiency of enzyme can aggravate. And only one rule out one list of this. There are a lot of other complements. So ADMTS 13 is the first. Whether the deficiency is complete, less than 10%, go for. Then diagnosis is confirmed. If not, then go for the other. If it is normal, then what?
Second is antifactories antibodies and complement factor mutations, sir.
Which is more common precipitating atypical HUS after delivery in postpartum.
Complement pathology mutations.
CFH mutations. Most severe and most common.
So you will go for them, you go for the genetic testing if it is available and patient is likely, then see for these regulations are likely to recur. So because the patient may ask you, what is my chance after getting this transplantation? And where we suggest them for both liver plus kidney transplantation, alone kidney transplantation, in where you have no eculizumab, what are the other options, how we can deal with. So read it about all these, so go systematically.
What is the current literature favors? Combined liver kidney or something else? For CFH mutation. Kidney transplant plus lifelong eculizumab.
Now eculizumab is available in India also at a little higher cost, so you can go for those who can afford.
Any other new drug has been under trial for atypical HS? Hmm? Any trial?
Trial going on, I have been in India, some
Yeah.
trials are there.
Oral tablet factor B inhibitor, iptacopan.
We have
Phase 2.
one patient post-transplant recurrence. But complement levels and other things becomes normalized. And kidney function also becomes stable. So I don't know.
How will you differentiate preeclampsia from a renal parenchymal disease? Both presenting with hypertension and proteinuria in the second trimester.
Other systemic manifestations will be there in preeclampsia.
What systemic manifestation in preeclampsia other than hypertension?
Transaminitis.
In HELP syndrome only. In preeclampsia, there is transaminitis.
Post delivery.
Simple investigation.
Serum.
Before serum, as a nephrologist, what will you look for?
Kidney cells.
Radiologist. Nephrologist will look for urine analysis.
Urine, what will that show?
Liquid biopsy.
If there is active urine sediment,
Sediment, RBCs, urine.
indicate a parenchymal hypertension. Any other new biomarkers?
Cephalic PAG.
Placental growth factor ratio also will tell you that this is preeclampsia.